Welcome to the Derm-It Trotter Don't Swear About Skincare podcast. On today's show, I've got Dr. Harrison Wen. He's a board certified dermatologist, but double board certified in dermatology as well as Mohs micrographic surgery. And he runs Harrison Dermatology in the Houston area. We're going to talk about HS today, one thing he's passionate about and treats patients very well with. Welcome to the podcast, Harrison. It's great to have you here.
Shannon, thanks so much for having me on. Looking forward to talking about hidradenitis suppurativa.
Yes. So I think this is something, I even said HS, and some people might be thinking, well, what are you even talking about here? So I'm glad you kind of spell that out for people on hidradenitis suppurativa, because it's something that, I've become passionate about. We run clinical trials in our office. We manage a lot of patients with this debilitating condition. And we're going to take a unique angle today. So Harris and I decided to get some questions from the patient perspective to really answer those for you so that you have an idea if you have HS or you have a friend or family member does, sort of, what they're going through, and really dispel some myths and spell things out for patients as well. So I wanted to get started with kind of, patients always with HS want to know, like, why did I get it, in my younger years? Some people say, I'm in my 20s, I'm in the prime of my life. Why am I getting HS now?
Yeah, thanks, Shannon. First, whenever I have a patient with HS that comes in my clinic, it doesn't matter if it's the first time they've received a diagnosis or they've received a diagnosis for many years and are coming to me for a second, third, fourth opinion. It's really important that I make sure that we're all on the same page. So I start with explaining what HS is and what it's not. What HS is, it's a chronic autoinflammatory progressive condition. And we break that down. Chronic, meaning we don't have a cure. Autoinflammatory, meaning that we have inflammation going on within the body. And it's progressive, meaning that if we don't appropriately control the inflammation, it will progress. But it's also important to educate our patients on what it's not. It's not an infection. It's not contagious, and it's not your fault. I want to make sure that that's very clear. We'll talk about things that are maybe modifiable in one's lifestyle that can be helpful, but really important to shift the blame away from patients. Now, to answer your question, why does this start in my 20s? Oftentimes, not always, but often starts in teenage years or to the 20s because it begins during or after puberty because it's influenced by hormones and the immune system. And your teenage years and your 20s are a time when your oil glands, your hair follicles, and your hormonal signaling, they're very active. And so, again, HS is not caused by poor hygiene. It's a disease of inflammation that starts deep in the hair follicle. And for many people, that's really what happens, and it shows up in early adulthood when some of those biologic systems are starting to peak and change in their activity.
Yeah, so it's good for them to understand that's not really coincidence, right? There's a lot of those physiologic changes you talked about that make HS a thing that pops up during that point in life. But I want to reiterate what you talked about, sort of that feeling of shame or embarrassment that a lot of HS patients have. And, really pointing out the fact that this isn't their fault. There's nothing that they can do necessarily about this. To a degree, there are some things that I will talk about that might help it, that they might be able to change lifestyle wise, but really giving people, that comfort, to come in and talk about it, because it can be tough because it affects areas that are definitely very sensitive, for people. So I like that you bring that up because it is one of the things I think that is a barrier for patients to get diagnosed, which is one of the other questions. A lot of, I'm looking through the list here and what's been submitted from patients here, why did it take so long to diagnose my HS? And I think you and I know the answer here. And, awareness is part of the piece of the puzzle. I think it's a bigger piece than sometimes we want to admit. But what do you say to your patients when they're wondering, why did it take so long?
Yeah, well, the average time to diagnosis in 2025, 2026 is around 7 years. And it's gone down from about 15 years, just about a decade ago. So in 2015, 2016, the average delay to diagnosis was 15 years. And we're about half that right now. We're still about 7 years too long, in my opinion. But why that's happening is that it's multifactorial. First, HS is often mistaken for recurrent boils or infections. And so patients will present to the ER or maybe to other specialties that aren't as familiar with HS, and so they don't receive the appropriate diagnosis, and maybe the prior clinicians just see what is in front of them, and they see it as a cyst or a boil, and they don't see the greater picture. The other factors that may that may affect it is that sometimes patients are embarrassed about their disease and the areas that it's affecting. Remember, as you mentioned, Shannon, it often affects areas that are sensitive. It can affect uh, underneath the breasts, but also the genitalia. And so these are areas that patients, they're embarrassed to talk about. And when they first start having symptoms early on in their, let's say, their teenage years or their 20s, they don't want to talk to their parents about it because they're afraid to talk about sensitive areas to their parents or to their loved ones. And so again, it's kind of coming from both sides. We're getting better. We're building awareness among the entire house of medicine. We're educating our medical students, educating our residents, educating our colleagues about HS. But we're also building awareness, on a public level. Social media has gone a long way in helping this. Things like, Instagram, Twitter, Reddit, things like even your podcast, Shannon. Being able to reach patients and notifying them about, if you have these spots, don't be embarrassed. Feel empowered to speak up and find care as soon as possible.
Yeah, I like that you highlight that because I think taking the stigma away is part of, one of our goals here with the podcast, but that piece too of educating our colleagues, because you're right, so many of us share in the care of HS patients because a lot of them might see their primary care doctor. They might go to the emergency room and see an emergency room physician, or they might actually go to their gynecologist or even a general surgeon. There's so many facets, of this disease of who's managing it. I think to create a better understanding and also kind of where we're headed in treatment for it, because we've made a lot of headway in treatment, although there's a lot more room, I know, for even more improvement on how we approach the HS patient with our therapies. It is an exciting time, I think for those patients too, that we're finally giving it the recognition it deserves and putting it in the spotlight as well. I had an HS patient that came in and asked me this question the other day. So I was going to have you touch a little bit on like the genetics aspect. I know we talked about the hormonal changes, autoimmune, but she said to me, hey, my husband and I want to start a family. They're in their 30s. They've been married now for a few years. And she literally asked me, will I pass this on to my children? So I want to get your thoughts on how you kind of handle that question, because, it's something that we do see at track in families. And I know it's a great of concern for her because of how she suffered with HS for so long.
Yeah, that's a great question, Shannon. There is a genetic component to HS. We see about one third to one half of patients with HS, they report a family history. And what I see in my clinic, I do see that, when I explain to patients what they're going through, that, this is a chronic condition, they say, oh, I think my mom or my aunt had it. And then conversely, sometimes we see patients bring in their kids because they're able to detect it a little bit earlier. But that, when this comes up in my clinic, I try to change it into an opportunity, saying, look, like, yes, there is a higher risk that you may pass this on to your children. However, because you have awareness of this is something you have the opportunity to talk to your kids about, to really break down the barriers, take away the stigma. And then when they're early in their teenage years, let them know about your experience with HS, so that if they do start to experience bumps or painful spots in the groin, underneath the armpits, or underneath the breasts, that they notify you as soon as possible, that they feel empowered to notify you. Because again, if we intervene earlier, we have a much better chance of preventing progression, as well as a better chance of our treatments from working. And so again, I try to frame it as an opportunity for our patients to really help change the trajectory of their kids if they do experience hidradenitis.
I love that because I do think for, when you start a family, you're already nervous, right? Everyone, you're going to become a parent for the first time. You're like, oh gosh, I don't even know what I'm doing. And already she's thinking about like, how would I handle it? Or, what's going to happen if my child happens to have HS as well. But I love that approach of the empowerment, to kind of put that, back into her hands that, what, you can really look for this. And like you mentioned, we do have therapies and things we can do to intervene earlier, which is something else I wanted to highlight because I feel like I get this question a lot too, is the progressive nature of HS. So one of the things I've seen for some of our HS patients that come in very early with this condition, they might be, what we call like a early stage 1 and kind of on the precipice of maybe developing scarring, evolving to a stage 2, or even for those with more advanced stage and 3, I think that's one of those things that people forget about the progression. If you started early on, could we intervene early and prevent that progression from happening? And I'm amazed at some of my patients that they're kind of intimidated by that thought of, progression and going on therapy. Then some are like, you know what? I don't know if I could take something lifelong. And it's been an obstacle for me. And this is one of the things the patient asked, if I have HS for years, is it going to get worse? And I said, well, the course can be unpredictable, right? Some people do have this more steep trajectory of progression, so people could be more gradual. There are some patients where it stays more stagnant, although we don't see that all the time. How do you sort of talk a patient through, if somebody's listening like, I'm hesitant to go on therapy to prevent it from progressing, what would you say to them?
Yeah. Well, first, I would say uh, that 2/3 of patients with early stage disease will progress, right? So you mentioned early staging. There's pros and
Mhm.
cons to early staging, but it's still a very common way to characterize HS. But early stage one is the earliest phase of HS. And when you have patients with early stage one, 1/3 of patients will stay in early stage one, and 2/3 will go on to progress from early stage. So that means they'll go on to early stage two and early stage three disease. So they're developing more scarring, more tunneling. It's impossible for us to predict which patients are which. But that being said, I know I'm not a betting man, but if I were, if someone gave me 2/3 odds versus 1/3 odds, I would intervene and put my money on the outcome with a 2/3 odds, right? And fortunately, we do have options that are effective and safe for treating HS. And we have currently 3 FDA-approved treatments, but we'll have more coming down the line. And the good news is, as more time goes on, we have more and more options that are effective and safe that you can be on long term. And so, just remember, this is what I would say to my patients: just remember that HS, as it progresses, it can be tremendously impactful, and it can have more risks and side effects if we don't intervene than if we intervene. And so just trying to encourage our patients to feel empowered that even though we don't have a cure, that we get them on the right treatment. And just, again, emphasizing the chronic nature. And something that patients understand is they tend to understand diabetes or high blood pressure. They probably have loved ones with both of those, and they are at high risk for those conditions themselves. Just in the same way that those conditions are chronic, we don't have a cure for that. We have to start often long-term treatment. It's the same way with HS.
Yeah, and I think that's a great approach too, because it's tough. I will tell you, if you look at just generational differences and how people maybe approach healthcare or medications, they've talked about Gen Z looking to be healthier. They're not going to the bars, they're not drinking. They're talking about how it's hurting, meeting people in the social scene and just how that's shifted sort of things for us as a society. It's interesting talking with a lot of them that concept of having to intervene early and go on medication can be a little daunting or scary, which I get, especially when you're thinking of this being chronic and potentially lifelong. But I love the way you talk about being kind of a betting person, because I think that can put that in perspective for them too, and give them a little bit more confidence that maybe this could be the right decision for them and their therapy. Now, one of the other questions that I wanted to bring up, because we haven't touched about maybe like what causes, flares to kind of happen. But one of the questions a patient asks is, what about stress, right? Stress is in everyone's life. We all experience stress, and they want to know, does stress make HS worse? And if so, is there anything they can do about it?
The answer is yes. Stress can make a lot of things worse on the skin. And stress, it activates cortisol and inflammatory signaling pathways. And so whenever a patient is experiencing stress, especially chronic stress, it can lead to immune activation, systemic inflammation, and some pain sensitivity. And so HS can be worsened by stress. But that being said, I wouldn't just chalk it up only to stress, right? In the same way we try to manage stress in general for the wellness and health of our patients, I wouldn't I wouldn't delay treatment or be less aggressive because we're just chalking things up to stress. It's not just in our patient's head. There's still that inflammatory component that we need to address. And so we want to address that. But if we can, let's try to address the stress as well. And so the mind skin connection, it's real. But again, it's not the only thing that we need to address when it comes to HS.
Right. And it's kind of a vicious cycle, right? Because stress can make HS worse, and then HS can cause stress for a patient. So we see that with a lot of different skin conditions and how those two can be interrelated. But stress is one of the things we call, a modifiable potential risk factor, to make things worse. What other things, if you're looking at, if you're thinking about other things that make HS worse that you might be able to modify, like lifestyle type changes? I mean, stress is a harder one to kind of change up, but what other things do you recommend to your patients? Because that's one of the things people are asking here, like, what else can I do lifestyle wise that might actually help my HS?
Right. So there are a couple other modifiable risk factors, and but I often don't emphasize this early on because I don't want patients to feel like again it's their fault. Sometimes they've been told right away from other clinicians that, oh, if you just lost weight or you stop smoking,
Right.
then this would go away.
Hmm.
Now, do patients get better if they lose weight? Sometimes. Answer is sometimes, not always, but sometimes. And do patients get better if they stop smoking, and specifically nicotine? The answer is again, sometimes, not always, but sometimes. And so that really gets at two modifiable risk factors. One is weight, and to that point, diet. So let's talk a little bit about that. So diet can be helpful, and so it's not always the same among patients. Some patients will get better, others won't. And there's not just a single diet that I can recommend across the board to my patients. Unfortunately, it's something that they really kind of uh, have to experiment themselves and see if they can tie to whether certain diets or certain foods trigger their disease. But we know diet can influence inflammation, and so general broad strokes is I try to recommend my patients to reduce intake of highly processed foods. Reducing high sugar foods, higher glycemic foods can be helpful. Reducing dairy can be helpful for some patients. And then also weight reduction if patients are overweight. And so something that I've added to my practice is a prescription and management of GLP-1s for HS. And I try to introduce this concept at the right time to patients. Again, trying to de-emphasizing that this is the only thing that's going to help them, or de-emphasizing that again it's their fault, because it's not. It's something that is only one piece of the puzzle that we can help modify. And the other one is reducing and trying to take away smoking nicotine, because we do know that nicotine, smoking cigarettes chiefly, but also vaporized vapes can make HS worse. And if we are able to remove that from a lifestyle, it can improve HS as one factor.
Yeah, I think it's interesting how you highlight that for, changing lifestyle, it's tough, right? It's probably one of the tougher things for us to do because we fall into habits, or sometimes, to cope with the stress, somebody's like, I smoke. I had a patient tell me that. They say, you're telling me to reduce stress, but I smoke to reduce my stress, but now you're telling me I can't smoke, which is just going to make me more stressed. So they were joking with me that, there was a lose-lose situation for them. But I think it's important, as you mentioned, that these are sort of, the add-on things, that you don't want patients to feel like you're accusing him of like, hey, you're creating this with all the things you're doing. But you're right, for some patients, it can be really relevant. I have had patients with weight loss, they've had significant improvement, and other patients maybe mild to moderate, right? So we don't, I think, fully understand the connection. I think each patient is unique and different. But GLP-1s that you mentioned, another question here, like, hey, I've seen GLP-1s, they can work potentially for psoriasis, seen it in the HS space. When would a GLP-1 be potentially right for me? So I was thinking you could maybe comment on some scenarios, maybe where you've added that into therapy or felt like it might have maybe a better role for maybe one patient over the other, or maybe you tend to use it in kind of more individual conversations.
Yeah, I rarely use GLP-1s as monotherapy with HS. It's typically as an add-on or adjunctive therapy in conjunction with another biologic or systemic for reducing the inflammation. But if I notice that patients are overweight or they're obese, I talk to them about introducing GLP-1 as part of their treatment regimen. And I try to talk about that not right away, because again, trying to de-emphasize things that are their fault. And most patients, I find they that are overweight, they know they're overweight. They try to do things that try address that, and they struggled, in their previous efforts. And so I introduced the GLP-1 again as a additional option, something that can help them in their journey to lose weight. I don't promise that it's going to help their HS, because sometimes patients will lose weight on a GLP-1 and it doesn't help their HS, but overall it does help them, by losing weight. So I think, if we can introduce that to the right patient at the right time, it can be very impactful.
Yeah, I'm excited where the research will go with this, because I think, as we're looking into this for other skin conditions like psoriasis as well, and there's clinical trials underway, I think it has potential to revolutionize some of the dermatologic conditions we treat where inflammation is at the heart of the pathophysiology. So I'm excited to see where it goes for
Yeah, me too.
HS into the future. But right now, we do have, a few medications that are approved and on the market for HS. So I was going to have you touch upon that, because people say, what are biologics and when are they appropriate? Like, when would I actually take one for my HS? So I was going to have you just comment a little bit on what's out there, and, when do you talk about starting one for a patient?
Yeah. So biologics are they're targeted immune therapies. So they block specific inflammatory pathways. And in HS, we have three. We currently have three FDA-approved medications. The first one is adalimumab. It was historically known as Humira, but because now it is the patent has expired. It's available in a biosimilar as a generic. That was the first treatment that came to market. What's kind of differentiates it is it's available for our teenage patients, and it can be helpful for patients with other comorbidities like inflammatory bowel disease, which we see often in conjunction with HS. Now, the second treatment to come to market, and by the way, Humira or adalimumab is a TNF alpha inhibitor. The second one to come to market is called Cosentyx or secukinumab. That's an IL-17A inhibitor, and that's approved for 18 and up. And then the third one is called Bimzelx or bimekizumab. That's an IL-17A and F inhibitor, again approved for our patients who are 18 years old and up. The next one coming down the line, although it's not available, we expect to be a medication called porvositinib. And then likely after that, we'll have one called upadacitinib, or also known as Rinvoq, on label for HS. That's my prediction. That's not, on behalf of anyone else. But we are getting more and more options by the year, and finding the right treatment for our patients is important. And when it comes to biologics, I often recommend early intervention. So if patients have a tunnel, for me, I typically start them on a biologic because of that already demonstrating progression. And even if they don't have a tunnel, but they have impactful disease, it's impacting their quality of life, having a flare too often or drainage or pain, then I will start a patient on a biologic at that point in time. And remember, biologic is one piece of the puzzle. It's rarely, for me, the only treatment on board. We have to add on things that address a patient's hormones. We have to often add on things that address microbial and microbial dysbiosis, not an infection, but
Mhm.
dysbiosis of the microbiome. And then we also have to add on different surgical options. And so it's just one piece of the puzzle, but early intervention with biologics or systemics can be very helpful for preventing progression.
And I think that gives people some hope, like you said, the fact that we have these medications available. We have a few more that'll probably be soon to be available. And a lot of research is going into HS. And the one thing to highlight too is that there isn't a one size fit all, like you mentioned. I think we find that there's some heterogeneity. I mean, everyone's immune system is a little different and dynamic. And so sometimes one drug that works for one patient doesn't work so well for the other. So it's great to have these options that are coming to the table so that we can really prevent progression and rein in current disease for our patients. Now, last, I want to finish it up because I think this is a really big thing to highlight with HS. A patient wrote in and asked, is HS linked to depression. I've suffered with depression all my life, but I feel like obviously HS has made it worse. But I've heard that HS patients can actually have increased, rates of depression compared to people who don't have HS. So I wanted to comment on the mental health aspect. It's probably one of, if not the most important thing that we actually deal with HS. Yes, we're focused on treating the disease state itself, but obviously mental health is a big concern for us as dermatologists.
Yeah, Shannon, that's incredibly important. And HS is associated with higher rates of depression, anxiety, social isolation. But it's super important to the patients out there who are experiencing this, and that one that wrote in, it's not weakness.
Mhm.
It's not because it's your fault. The depression is a result of multiple things. It's a result of chronic pain. It's a result of drainage and odor and scarring, systemic inflammation that can also have an impact on the brain, and then of course it can be a result of feeling misunderstood. And so mental health care, super important part of treating HS. And so we encourage all our patients out there with HS, if you are experiencing depression, anxiety, social isolation, make sure you verbalize that to your dermatologist.
Yeah, and I think too, we have a duty too to kind of investigate a little further and ask patients, because you're right, they might, as much as they're embarrassed about the HS, sometimes people don't want to bring up the fact that it's preventing them from, dating, or maybe, applying for that job, or, just doing everyday functions. I have a patient that had a hard time just raising her arms, to put groceries away in her cupboards. And, how that impacts you. We all take for granted some of those things we get to do everyday life. And I think for some of our patients where they're just not able to do those, we have to sometimes sift that out and kind of, through all the noise of kind of the medical visit, remember that mental health is still a part of the medical care we can give to patients. And as dermatologists, we can play a pivotal role in that. And if it's not something we manage directly, we can get them resources into the right place. Well,
Absolutely.
Harrison, I got to tell you, this has been great. I think patients are really going to appreciate the insights that you've really brought up today and answering their questions. I know, like myself, you're passionate about treating HS, so I appreciate you sharing your expertise with our listeners.
It's my pleasure. Thanks so much for having me on, Shannon.
Of course, we'll have to do it again. And stay tuned for the next episode of Derm-It Trotter. Don't swear about skincare.